Ladies and gentlemen, welcome back. Now we will move on to the roundtable discussion. The title of the roundtable discussion is aligned with our main theme, advancing digital health for physical activity and nutrition policy transformation and governance. The section is designed not only as an exchange of ideas among our distinguished panelists, but also an interactive discussion with all participants. Questions, comments, and reflections from the audience are all welcome. We are honored to have several distinguished panelists with us today. Please allow me to invite them to the stage one by one. First, Dr. Susan Jung-Su CHANG, the professor of the School of Nutrition and Health Science in Taiwan University, is welcome. Next, we invite Dr. Junbok LEE, research professor, Yonsei Institute for Digital Health in Yonsei University from Korea. Let's welcome. Next, we invite Dr. Takehiro SUGIYAMA, director of the Department of Medical DX, Japan Institute for Health Security from Japan. Let's welcome. And also, we invite Ms. Audrey Tong, Director of the Integrated Solutions and Program Planning Office from the Health Promotion Board in Singapore, as welcome. And then we invite Dr. Yu Hong Zhang, Project Assistant Investigator from the Institute of the Population Health Science from the National Research Institute in Taiwan. And for this roundtable discussion, we are also honored to have two esteemed scholars serving as the moderator. Let's welcome Dr. Hong-Yi Chiu and Dr. Ya-Wen Chiu. Please come up to the stage.
Okay. And I highly appreciate all the participants.
工会促进会通报，刚刚为国际部报CHIU计划，CHIU计划。
I will appreciate all the participants in this room who stay from the last yesterday afternoon to today morning section. And I think you hear a lot of the good project from Singapore, South Korea, Japan, and also Taiwan. And yesterday we talked about how to implement the project and the goal and how the outcome. And today we focus on how the project can be the policy. So because we don't have time to receive any questions on the floor, so I will take this time to welcome all the participants to raise your questions to our five distinct speakers. So now the time is yours. Okay? Please raise the question. And before you raise the question, please identify yourself and specific your question is to which the speaker you want to ask. Okay? Okay?
Hi, I'm CHIU. I'm from Health Promotion Administration. My question would come to Dr. Yu Hong Zhang, and because we've learned a lot from all the incredible projects from Japan, Singapore, and Korea, and done a lot of amazing devices from your country. And I noticed that you sharing about you monitor the heartbeat, sleeping time, and eating records, and so on. But my question would come back to the evaluation assessment. Is current EA enough to fully capture what really happened to individuals' health? When it comes to people-centered driven policy, I'm wondering, it seems hard to exclude people's lived experience and their true stories in life, and how would this kind of evidence be collected in the near future, or do you think is the next stage? It will happen in the next stage. Thank you.
You mean the next stage and how our assessment can be applied to healthy life? Or, sorry. So, your question?
I think my question would be like, because I've seen all the sharing projects today and yesterday, and because you have all the data, and my question will be, is that the data could tell the full story of what really happens to people's health? Because it seems like we only see the numbers and tell the stories, but is that really the full story behind that? And do we really know what really motivates people to use the device, or what really motivates people to do all the health behaviors?
Okay, so the tool is based on the theory of change. So in the theory of change, the logic model, you can see the final endpoint is health outcomes, is including a change of health behavior. So my job or my task is to develop a tool that help the decision maker to scan or to diagnose program, health promotion program, and we can see what the information is missing. If we want a full evaluation, outcome evaluation, so what is still missing? What important part we should have in the outcome evaluation? So it's not directly to some specific type of behavior change, but I think the tool can help decision maker like a government to manage their project. Yes, thank you.
Any question? Okay, Dr. Chan. Yeah.
I'm Dr. Sai from the National Tsinghua University, Department of Public Health. My question is to Dr. Professor Jung-Su. Because I know the metropolitan city like Taipei, many families actually are eating outside. So the restaurants serve food that appear to local taste. So that is a big problem. Eventually, in an individual, people want to be taking healthy food. However, most occasions they is eating outside, and then the restaurant serve food to suit people's taste. So, and then that became somehow a cycle. Even if the people would like to choose a healthy food, however, the restaurant provide a spicy food or the sushi or all kind of food, and with high salty oils and just unhealthy. But people like it. So that's a very very ambiguous or very contradictory to the scientific nutrition science. So it can be the reciprocal change that if the people favors healthy food, so that even the entire home also will modify their flavors, components to shoot the trend of the healthy food trend, or that's or just they or assume how people don't care, but because it's so famous restaurant, and so the people has to adapt into the entire home's flavor. So what's your comment based on the occupation? Thank you.
Thank you so much. I think in terms of the food preference, there are two important stages which occurs to influence what foods we prefer. The first is during the childhood, which mainly influenced by your parents. The food your parents eat most, and that's kind of like a digital imprint into our food taste. So the first important, as mentioned in other, like even our government's Shujiang, it is important to educate the food preference as early as possible, especially in the kindergarten stage, because which is the place children start to change their food preference after they kind of go into the peer in the kindergartens. So you see young kids, oh, I don't like the carrots, but if another kid says, oh, I like it, this kid may say, oh, maybe that's not bad. They will try to test carrots again. So I think the peer pressure as earlier as in the kindergarten is very important. Another is of course, elementary school. And so I think that we don't know. Our food preference is kind of whether it's coming from genetics or the mixture of rural environment. So this you can say both. Another, I think the important is during the midlife stage. As Director Audrey said, actually, we have so many choices, and we cannot just easily persuade people to eat healthy food, even though, yes, we think it is important. Message alone never be enough to make people change their behavior. So, but what governments can do is like in Taiwan or in Singapore is to try to persuade the company they should have their social responsibility to reduce like salt or sugars. So that's required collaboration at the company side. And in addition to the education and to reason and encourage people to change healthy food. But during the life cycle, especially in the midlife, all the literature told us, if you suddenly have a substantial weight gain in your mid-life stage, then you will be more likely to develop a chronic disease. The risk is increased. And so that is why I say, even though when I was young, I was a dietitian. And when I was young, I still drink like a bubble milk tea, and I ate fried chicken, and I said, okay, my blood, lipids, glucose, they are absolutely fine. Everything is green in my health checkup. So I just thought, well, maybe that's not that important. But in the age I'm facing now, actually I cannot eat as much as what I used to do. And my health, the biochemistry check, the lipid is gradually increasing. So this is why I say, in the midlife, we face the hormone changes. And so this is another turning point. Even if we are the individuals, we think, okay, that maybe I still like this food, but I think we have to remind ourselves, we have to a little bit control. You still can eat fried chicken, but just reduce the time that we consume that one. So I think that is the life we are surrounding. So we need an environment to support us as well. But individual, we also have the responsibility. So I hope I can answer you a little bit. Okay, thank you.
Okay, any question on the floor? Okay, I have a question.
Okay, hello, I'm Diana. I'm a postdoc at Academia Sinica, and my question is for Ms. Tong, because I'm very interested in the Singapore, the Nutri-Score system, the ABCD. Is that borrowed from the European Nutri-Score? Does it come from that, and is it the same? And then also for the healthy restaurants, how is that evaluated? Like, how are they checked that these recipes actually follow a very healthy diet? Like, how does that happen? Thank you.
Can you, yeah, thank you for your question. So maybe on the Nutri-Score first, yeah, it is adapted, not exactly the same, but adapted from the European countries. We've spent quite a lot of time learning from them. And I think in Europe, they actually have a 5-point scale. Ours is a 4-point scale. It's intentional. In terms of your question, in terms of healthy dining at the restaurants, so maybe just give some context. In Singapore, we have the restaurants, we have the hawker centers, and then we have food courts. Predominantly, about 70% of Singaporeans tend to, on a daily basis, they tend to frequent the hawker centers and the food courts because it's cheaper in price, etc. And it's fast. In those cases, actually what we've done is that because most of the meals are similar across these establishments, what we do is that our nutritionist actually does food tests, as they take the samples, they put it into, I think there's this machine that they put it through, and they do all that kind of readings, and then they roughly estimate as such. So that's the program that we have in the hawker centers and the food courts. And we do that labeling based on that as well. Of course, plus minus some margins, yeah. For the restaurants, it depends on whether the restaurant is interested to participate in a healthy dining program. It is not mandatory, but if they participate, that's where the government, as part of our campaigns and as part of our gamification, we actually do support these restaurants who encourage, meals that are healthier in that nature. And maybe to the surprise of many, we even work with restaurants or fast food chains. They may be termed unhealthy, but like I mentioned earlier, our whole intent is that if someone wants to eat something, they want to eat that. But even in that category, how can we make it a little bit healthier, whether it's through the oils or whether it's through salt and sugar, etc. So that's how we address the food situation in Singapore. I hope I answered your question. Thank you.
Okay, Madam, question?
Hello, I am Hay, and I'm currently a master student in public health with a background in nutrition, and I have a question I want to ask Dr. Su-Rong. And I'm interested in developing a tool that applies AI to dietary assessment. I was wondering if you have compared different AI models such as GPT, Gemini, or Cloud for food image based on dietary assessment. If so, what criteria do you think are the most important when selecting a model? Thank you.
Your question. Actually, we tried, the first large language models we used was ChatGPT 3.5. At that time, we was kind of using the model, deep learning model, convolutional neural network as an algorithm to train our own food image AI, detection AI. But along the way, ChatGPT, caused the global phenomenon. So we start testing the ChatGPT 3.5. So along the way, now, we also test like a Gemini 2.5 Pro or even the newest model. And we also test like a closed source and open source. So like commercial large language models like ChatGPT, OpenAI, or Google Gemini, they are all the closed source. So we are not able to download their AI models. But we also have the open source like DeepSeek and Llama. So if you want to build your AI model, I think that maybe you can consider, especially if the NVIDIA's AI notebook is released, maybe I think that everyone should build up our own agentic AI in our laptop. And as well as you can train your AI model using the open source model. That is what I suggest if you have interest in this area. But I tried to fine-tune the open source model Llama last year. And actually, the AI trouble became worse. So this is about this year, the summertime, if I recover. I also want to train again using the closed source. So you can try first to use the closed source, sorry. Yeah, you can use the open source. Open source closed source is a little bit confusing. So that means the commercial one is closed. So closed source is for commercial one. That means we cannot get access to the AI model. Okay, so I'm sometimes confused. So, but you should try to use a variable like a ChatGPT or Gemini. I can tell you, last year when the ChatGPT 4.0, it wasn't performed well compared to Gemini 2.5 Pro. But this year, they are kind of outcompete the Gemini 3 version now. So I can tell you which model to use depends on your preference. At the moment, I can tell you, like our American collaborator, their recent application, they also compare the GPT, Gemini, and Llama, and Anthropic. I can tell you, from their American data, it's very similar. So I mean, the AI model is already good enough, really, but they are not perfect. We have to remember, they never be perfect, because data assessment is as complicated as you can imagine. We have new foods created by the industry, and the portion size is changing and changing. So you see, that is what bother dietitians. We are able to collect those information immediately. But people are already eating these new trendy foods. So we are also left behind. But AI can help is because if you use the closed source model, they can update like 3 months to 4 months, depending on their capacity. So they can capture the newest industrial food, which we, as a government or as a dietitian, we never be able, has the energy to collect such up-to-date industrial data. Yeah, so this is why I think there is an advantage of using large language model. But as I said, they also have the problems. So for me, in order to improve this AI accuracy, we need to do either like a prompting strategy or tailoring towards to your regional or nutrient database or your personal interest population or target. So that I certainly think you can choose either one of the closed source AI model and try to use the customization. Yes, we use customization and which perform better than the base, like a model. So that's something I think we just have fun. Just play it, yes, and you will gradually understand how to work with AI. Okay, thank you so much.
Any question?
My question is to Director Andrew Donald. As in Skinner's theory of the optimum conditions, environmental stimulus could set the catering of the behavior response, but the response decrease if the reinforcement is withheld. A process known as the extinction. When reward stops following the actions, the learning behavior gradually weakens and eventually disappears. So it's the Skinner's Occam's conditioning theories. Could say it happened that in the Singapore, when you use redeem point as an incentive for the people to keep some physical activity or healthy diet. I wonder if the incentive will decrease. Actually, when people are indebted to the system, and there is no further reinforcement. So what's your comment? Thank you.
Hello. Yeah, I'm not so sure I understand your question. Can I rephrase it that you're asking my comment with regards to the helpline systems that we have and whether it has been successful? Yeah. Is that what you're asking?
It's somehow like the redeem point for people to redeem in this bonus by the health promoting behavior is somehow like a stimulus, and so people have the redeem point is somehow like an incentive to attract people to do to perform the behavior. Once the redeem is decreasing, or the people have been adapted into the model. I mean that they will reach a plateau period, so no further improvement anymore. We'll get a plateau. So, that's my point. And how is it happening in the plateau stage in this mechanism? And how could you further reinforce the people keep going on sustain this behavior?
Okay, Ken, thank you. I think I got your question. So yes, actually through our National Steps Challenge, which I've shared yesterday, which has been over 10 years right now, we actually do see that some people actually plateau at some point, but we also see quite a significant proportion of the population who participate in it actually continuing beyond the incentives that we have given. So I had mentioned about how the Healthy 365 Act alone is not the one and only mechanism to get people active or to live healthier. We do have many other frameworks in place. The Healthy 365 Act is just one. The other is also we look at whether through our surveys, whether people are increasing their healthier living habits. We continuously also adapt and change our nuancing of the app. We spend a lot of time on behavioral science right now to see what motivates individuals and how to get them continuously engaged. And then of course, we have on-ground activities to keep individuals wanting to do more. So that's generally the trend that we are looking at in terms of looking at different aspects of what we have in the system, rather than just looking at Healthy 365 as the only one and only mechanism to get people moving or to get people exercising. Yeah, so I'm not sure if I've answered your question, but we have seen indeed some people dropping off, but large proportion continues, and for those who drop off, they potentially could have already been self-sustaining on their own and they don't need our app, or they may have migrated to another app that they are willing to pay for, as an example.
Okay, next question. Okay, there.
Yeah, thank you to all the panelists today for their incredible presentations. My name is Terry. I'm a master's student in NTU's Global Health program with a background in public health. I have one question for Director Tong, and then one question for, I think, all of the panelists. Anyone can really jump in. The first question I had was in regards to health promotions for desserts. I was very interested in Singapore's strategy of providing a healthy alternative instead of telling people, no, don't eat that, which I think is a really novel nutrition approach. And I was very interested in hearing more about what a healthy dessert might look like in comparison to what might be considered unhealthy dessert, and what are the substitutions you make to provide this healthier choice for consumers. And then the second question I had, which was really for, again, any of the panelists, I'm really interested in all of your research. I think that there's a lot to be excited about when it comes to the field of promotion and prevention of NCD. I was just wondering if there's anything in particular that you think is an interesting future application of your research, and something you think that from your research you found can be applied more broadly in the future. Yeah, thank you.
So maybe I take the first question first in terms of dessert. Yes, that's indeed a challenging area. For desserts where you can control the amount of sugar that, when they add it on, that's when actually we educate the public to ask for less sugar. I shared earlier on the movement we have in terms of ask for less sugar, ask for less salt. It's the same premise that we go on. And then of course, in some cases where that dessert can have less sugar upstream where it's being made, that's where we would then put on our label. So I talked about how we work with fast food chains earlier as an example. There's always a healthier alternative within the fast food chain. Yeah, doesn't mean you cannot eat that. Yeah, but for the rest of the other desserts, that's the challenging part, which we are still grappling with. So we've tackled a lot in the beverage space. Yeah, so like the likes of all your bubble teas in Singapore, we do have key bubble tea players working with us where by default, whenever someone orders a bubble tea, by default, if you don't tell them anything, they will already give you less sugar unless you specifically ask for more sugar. Yeah.
Okay, proceed.
Yes. Okay, thank you. So I have a question for our guest from Japan, Dr. Sugiyama. Congratulations on your presentation today, because you just demonstrated us a very successful starting point by pinpoint practitioners. Okay, you think PHR is a tool, very good tool. However, to link this tool with the participants, not patient, but participants or people, you need some very strong facilitators. So in your study, you use practitioners, which include nurses and physicians. And then you build a behavior change model by using the very typical proceed concept. And then you develop the handbook already in Japanese, right? Yeah, so two very quick questions for you is that how, because I have to talk about the Taiwan environment a little bit. In Taiwan, I think the physicians and nurses are already working in a very high stress environment, too many patients, because the health care quality is too good. So all people like to go to hospitals a lot. So they actually have to do a lot of things at the same time. So how can you increase the interest to participate? I mean, how can you increase the interest of nurses and physicians to join you and help to facilitate, to persuade people to use the tool? That's the first question. And the second, can you possibly in future share the handbook in Japanese to the other Asian worlds if you really become very successful in Japan? Thank you.
Thank you very much for your questions. And the first one is about the greatness for the facilitation of the guidance using this handbook information. So let me clarify the situation of the health guidance in Japan. So health guidance is not the clinical medical things. So clinical medical things is reimbursed from the insurance, and therefore the diseases, not the prevention. So, but the health guidance is not covered by the insurance. But the insurance should give the health guidance if the one particular person is like obese or have some blood pressure or this metabolic syndrome. So this is apart from the reimbursement system, the medical things. So and the health guidance is the facilitator of the health guidance is like a dietitian or public health nurses in like a company or the and they are they give the health guidance through the yeah, so they have some contract with the health insurance, like the municipal insurance or the company insurance or these things. And they have contract, and this company gives some his guidance to the participant from the beneficiaries, right? So they are quite separate. So clinicians and the public health nurses or dietitian in that case. So I think because the system is like 18 years old since 2008, so there are many companies or there are several public health nurses or dietitians prepared for this system. So, but they are now encouraged or enforced to, they are forced to get the outcome, good outcomes, or lower their average body weight for the participant, like that. So, I think there are many people engaging in this. There are so many opportunities and there are many people like that. And that's the first question. And the second question is about the translation of the handbook, right? I think this is the first edition for us that just published in this March. So I think we need to revise that during our experience in Japan, but after that, if it's good for it's allowed to translate in other languages, yeah, we're happy to do that. Thanks so much.
Okay. Any question?
Can I have another question? Okay, for our guest from Korea. Okay, so I have to say that Korea has a lot of new ideas, and I think Korea can be a very strong competitor to Taiwan very soon, already a very strong competitor. And I noticed that in one of your slides you have KHIDI, Korea Health Industry Development Institute.
Yeah.
Perhaps you can elaborate about the function of this institute to us a little bit more, because this is something very new. We have never seen this in Taiwan before, because so far health doesn't really link to industry so well in Taiwan. So we envy you. And I have a second question for you is that since you talking about all the healthcare journey with AI, powered by AI, but how do you plan to increase your people's trust on AI? And how to increase people's AI literacy in the near future? So there's a total of 3 questions. Thank you.
Thank you for the question. Actually, KIHID is kind of a government institute for they cover the R&D project, so they fund to the industry or companies. So many R&D things about digital healthcare or healthcare service, they fund to the hospital or and companies. And about the trust and the literacy of the AI, actually, as I talk about the DTX, DTX is kind of the medical device. So they need to get the approved from the KFDA. So it's kind of so they need to prove the safety and effectiveness. So it's so that's why the products can be shared, trusted, and should trust. And about the literacy, I think it's the very difficult things to solve on, because the AI literacy is different from age, because many young people tend to use AI like GPT or Claude or Gemini, but older people are not using the AI. So I think we need to AI literacy is to need to solve, but many education for older people hands to older people. There are many education. So these kind of programs to solve the problem. Thank you.
Any questions on the floor? Okay, I have a question for speakers from the different countries. I think the low birth rate and getting old is the public health serious challenge facing in every country. So from the health economic issue, we don't want people then go to see the doctor, it costs a lot. So preventive medicine is health very important. I think very agreement in the country. So for your excellent model and your implementation in the future, what's the main challenge or what's the bottleneck you need to conquer? Just like the Singapore, I'm very impressed with their model, the health 365. But right now have 3 million people, they have 2 million people involved in this program. But Singapore have, I remember maybe 600 million people. Maybe 2 million, maybe 3 million, maybe you were the city. Another 3 million might not be joined. I guess. So in the future, the role of the government, the role of the community, the resident, what you will plan to make sure this program sustainability. Even in Korea, something like that. Though you have many incentives, you try to invite or attract the people, but just like the Taiwan, very difficult. Yeah, the health literacy is very difficult. Yeah, so Japan is the same problem. So I'm curious about it. I'm very interested about what your opinion to see your future, how to sustainability your program.
Thank you for your question. Maybe I go first. So I mentioned yesterday that we have three areas that we basically look at. We look at the government looks at Grow Well SG, which is actually targeted for the children. Then we look at Healthier SG, which is targeted for the general population. And then the last bucket is what we call Age Well SG. And Age Well SG is an initiative that looks at the seniors 50 and above. Some say 60 and above, so it really depends. The Healthy 365 app is there to help the seniors who are digitally savvy. You can do prevention exercises, etc. on the app. On ground, we also have a lot of active aging agencies, what we call AACs in the neighborhood, and these actually kind of addresses at the community population level and encourages the seniors to lead a healthy lifestyle. You can find many active aging agencies or community areas just within 200 meters from your house. In terms of the challenge moving towards the future, I think where the app plays a part is that we want to be able to reach to the state of precision public health. We've already started, as I've shared, but I think right now we are still very much grouping them into the different segments based on their interaction with us on the app. The ultimate goal is to reach an N=1 kind of model where we know or we can address every single individual based on their interaction with us and what they feed us, and of course knowing the kind of information we could get from the clinicians. That is the challenge that we are working towards. I mean, it's been a few years right now and we are still trying to get data exchange. It is challenging, but there are already inroads in many areas, so I think that's an area that we continuously work on, and that is where we believe the Healthy 365 app can actually help individuals. The more we know about you, the more we can then help you. But that, again, I just want to come back that the app itself is not a silver bullet. There's many other mechanisms on ground that supports each other. That's why at Health Promotion Board, this is very important for us to work with all the other ministries. And I talked about the hardware and the software yesterday as well. That's the reason why we are now ensuring that, whatever we work on, it fits into the life of individuals, especially when individuals are aging and they may not be as mobile as they will be currently. Yes, it's compared to current. Thank you.
The next challenge we will face in the future in Japan. So I think in the mainstream, I think we will provide some digital services like picture or the AI support or these things. But I think many younger people can follow that and use that. But I think some elderly person or elderly person, especially elderly person living alone, cannot catch up these techniques. And I think the digital divide can be there. And I think we need to follow up the people. But I think the equity and efficiency can be dilemma, right? So in that case, if we focus on these digital people who has lower literacy of the digital technology. So that is time-consuming and money-consuming intervention. So we need to think about that. So I think those who are very at high risk of the disease progression or the many worse outcome are not likely to use the application or not going to the health checkup, or so they are not visible, right? So in that case, we need to make these unseen, unobserved people. So we need to make them visualize, and we need to talk with them, and we need to focus on them, and we need to find how to solve the problem efficiently.
Korea, actually, I know the engagement for people for the public health system is very hard in Korea as well. So, Korean Public Health Center run mobile healthcare program, and for the program, for medical professionals join the program, so they consult with the participants. So doctor, nurse, and exercise expert and nutritionist. So so many professionals give the participants the medical content, and the content what they need is helpful. But it's very costable, and it's very expensive to hire all the people. So I think AI can solve this problem, but in order to develop the nice AI, we need to gather the data. So I think it's gonna be challengeable to gather the good data. So because there are so many data for developing the good AI, but as you know, the data is very scattered. It's from hospital, from the EMR, it's built from application, it's from the and something like that. So and so it's very difficult to gather even in hospitals. So they have their own EMR systems, so they do not have the standardization. So it's very hard to gather the data. So I think it's the challengeable in the era of the AI.
Thank you. I think this is a very tough question, and everybody try to find a solution. So we need to incorporate each other in the future. And I think the four countries in Asia and the leading country, we have good, we have very many expertise in the different countries, and so many problems, so many solutions. So I hope in the future we can share each other for innovating solution under the umbrella of the APACPH. So the APACPH is a very good consortium for every country. Okay, so I think the time is up, so I needed to close this roundtable session, and we are sent again our excellent panelists, and also I thank all the participants for your very good question. And thank you. Okay,
Thank you all for your